After learning about the basic concepts of acid-base disorders, let us see how we approach an arterial blood gas report and finally lead to the interpretation of such a report. Before that, we have to know certain values, their ranges, which are found in a ABG report. The first and foremost is the pH, with 7.4 pH is considered normal, 7.35 is acidemia, and more than 7.45 is alkalemia. So 7.35 to 7.45 is considered normal. The serum bicarbonate range is 22 to 26 millimoles per liter, PCO2 is 35 to 45 millimeters of mercury, and PaO2 70 to 100 millimeters of mercury. We can also assess the anion gap. Some consider sodium and potassium as the principal cations, where the anion gap will be 16 plus minus 4 milliequivalents per liter, and where we exclude potassium, it is 12 plus minus 4 milliequivalents per liter. Now, what is actual bicarbonate? Actual bicarbonate is simply the bicarbonate level actually present in the blood sample that we get in the ABG report. Now, it will vary with the PCO2 level. And standard bicarbonate is the bicarbonate level that would have been present presuming normal PCO2. This reflects the true metabolic status of the patient. What is base excess? It is the amount of acid or alkali to be added to the blood sample to restore pH to 7.4, assuming PCO2 to be 40 millimeters of mercury. It varies from -2 in metabolic acidosis to +2 in metabolic alkalosis. Now, compensation. Whenever there is a deviation in the pH, our body tries to compensate and bring back the pH towards normal. So, if we have metabolic acidosis, there is primary fall in the bicarbonate level, which leads to drop in pH. Now, here the respiratory system compensates by hyperventilation, leading to secondary fall in PCO2. As carbon dioxide is an acidic molecule, so drop in PCO2 will lead to rise in pH. And this drop occurs to the extent of 10 to 15 millimeters of mercury. Full compensation takes about 6 to 12 hours. In case of metabolic alkalosis, there is a primary rise in the bicarbonate. So here there is a compensatory drop in ventilation to cause a secondary rise in PCO2. But this rise is limited by the hypoxia, and it rarely goes more than 60 millimeters of mercury. In case of primary respiratory disorders, renal compensation occurs either by increasing or decreasing the resorption of bicarb and excretion of protons. Full metabolic compensation takes 3 to 5 days, so the renal compensation takes a bit longer to be established fully. Now, this is a very important slide which shows the extent of compensation in different acid-base disorders. There is variation in the level of PCO2 or bicarbonate levels depending upon, respectively, in case of PCO2 the bicarbonate level, and in case of bicarbonate level the PCO2. So one depends upon the value of one depends upon the value of the other. So this is depicted by different formulas which has to be applied during the interpretation of arterial blood gas reports. Now let us see how we detect acid-base disturbance and how we convert or reach a diagnosis. So first we see the pH. If the pH is low, then it is acidosis. The second step is to look for the PCO2. If the PCO2 is low, then we have to think that pH and PCO2 going in the same direction. So if both are going in the same direction, it is a metabolic disorder. As the pH is low, so in this case it is a metabolic acidosis. Now, what is the primary change in metabolic acidosis? It is a drop in bicarbonate. So drop in PCO2 is a secondary compensatory effort. Similarly, if we find low pH and rise in PCO2, so that means pH and PCO2 are going in opposite directions, and this shows it is a respiratory disorder. As the pH is low, it is a respiratory acidosis, and the compensatory change is rise in bicarbonate. So similarly, we can go to the alkalosis group and deduce what is the primary disorder going on. In simple metabolic acidosis or alkalosis, the PCO2 values are as per expected compensation with respect to the bicarbonate level. We can see in the previous slide, as we have already mentioned. In simple respiratory acidosis or alkalosis, the bicarb level is as expected with respect to PCO2 levels. Also compare measured pH with expected pH, which is given by this formula. The principles of ABG interpretation. During compensation, bicarbonate and PCO2 move in the same direction. If they move in different directions, then it's a mixed acid-base disorder. For example, in metabolic acidosis, the bicarbonate level will drop, and the compensation, what compensation is expected? Carbon dioxide drop is there from the side of the respiratory system. And if in alkalosis, where the bicarbonate level rises, there is a compensatory rise in the PCO2. pH and PCO2 change in the same directions in cases of metabolic problems. Amongst pH and PCO2, if one is normal and the other is abnormal, then it's not compensation but mixed acid-base disorder in opposite directions, like respiratory acidosis along with metabolic alkalosis. Disproportionate decrease in chloride with respect to sodium is either metabolic alkalosis or respiratory acidosis. Similarly, disproportionate increase in chloride with respect to sodium is metabolic acidosis or respiratory alkalosis. Now, if the measured pH is equal to the expected pH, then no compensation has yet occurred. Any deviation from expected compensation indicates mixed disorders or uncompensated disorders. ABG analysis in different situations. Now let us take the example of acute respiratory acidosis. First of all, we measure the pH. Now if the measured pH equals to the expected pH as per this formula, then it is in the uncompensated stage. If the measured pH is less than the expected pH, then besides the respiratory acidosis, there is another acidosis going on, which is dropping the pH further. So in this case, there is respiratory acidosis along with metabolic acidosis. Now if the measured pH is more than the expected pH, then two things can occur. Either there is a compensation going on or there is an alkalosis component along with respiratory acidosis. How do we differentiate? We measure the bicarbonate. If the measured bicarbonate is equal to the expected bicarbonate, then it is a compensated respiratory acidosis. But if the measured bicarbonate is more than the expected bicarbonate, it is respiratory acidosis as a primary disorder along with metabolic alkalosis. Similarly, we can take the example of respiratory alkalosis. Again, we measure the pH. If it equals to the expected pH as per the formula, then it is an uncompensated state. And if the measured pH is more than the expected pH, then besides respiratory alkalosis, metabolic alkalosis is also taking part in raising the pH. If the measured pH is less than the expected pH, then either an acidotic component is there, that is respiratory alkalosis with metabolic acidosis, or the respiratory alkalosis is in a compensated stage. And this is differentiated by measuring the bicarb level as shown. Similarly, take the example of metabolic acidosis. Now here we will measure, because there is a drop in bicarbonate and compensated drop in PCO2, so we measure the expected PCO2. Now if the expected PCO2 and measured PCO2s are same, then metabolic acidosis is said to be compensated. If the measured PCO2 is more than the expected PCO2, then along with metabolic acidosis, there is also respiratory acidosis. And if the measured PCO2 is less than the expected PCO2, then there is respiratory alkalosis going on along with the primary metabolic disorder, that is metabolic acidosis. Similarly, in case of metabolic alkalosis, again we calculate the expected PCO2. If the measured PCO2 is equal to expected PCO2, it is a compensated metabolic alkalosis. And if the measured PCO2 is more than the expected, it is metabolic alkalosis plus respiratory acidosis, because this PCO2 is rising because of acidosis component or respiratory acidosis component also. Now if the measured PCO2 is less than the expected PCO2, more carbon dioxide is being washed out. So therefore there is respiratory alkalosis along with metabolic alkalosis. Now this is a typical ABG report which we. Now let us try to interpret some ABG reports. The first one, pH is 7.32, PCO2 is 27 millimeters of mercury. Both are moving in the same direction and they are low. Therefore, it is a case of metabolic acidosis. What is the expected PCO2? It is 27 to 31 millimeters of mercury, which is equal to the measured PCO2. Therefore, this is a case of compensated metabolic acidosis. The second case, here the pH is 6.8, PCO2 is 90.5 millimeters of mercury. Both values are moving in opposite directions. Therefore, it is a respiratory acidosis. Now, what is the expected pH? This is 7. So, the measured pH is less than the expected pH. So, therefore, the final diagnosis will be uncompensated respiratory acidosis along with metabolic acidosis, which is reflected in the low bicarbonate level. In the third case, pH is 7.18, acidotic, PCO2 15.75, again low, both are low. So, this is a primary metabolic acidosis, which is also reflected in the low bicarbonate level. What is the expected PCO2? This is 16.5 to 20.5, which is more than the measured PCO2. So, the final diagnosis is uncompensated metabolic acidosis along with respiratory alkalosis. In the last case, the pH is 7.49, which is on the higher, more alkalosis. PCO2 is 43.5 on the higher side. So, both moving in the same direction. Therefore, this is primary PCO2 is high, pH is also high, so moving in the same direction. Therefore, it is primary metabolic alkalosis. And then we calculate the expected PCO2, which is 48.4 to 52.4 millimeters of mercury. Therefore, the expected PCO2 is more than the actual measured PCO2. So, the final diagnosis is metabolic alkalosis along with respiratory alkalosis. Now, a 12-year-old presented to the OPD with complaints of progressive loss of weight, increased appetite, polyuria, and increased thirst. On examination, ill looking, tachypneic, chest severus normal. Here the pH is 7.26, lower side, PCO2 16 millimeters of mercury, lower side, bicarbonate is also low. So, we see that pH and PCO2 moving in the same direction, and so the primary problem is metabolic, and as the pH is low, which is acidotic, so primary metabolic acidosis. Now the question arises whether this is compensated, uncompensated, or mixed, and what is the anion gap. So to answer this, let us find the expected PCO2, which is 16.65 to 20.65, that is almost equal to the measured PCO2. So therefore, this is a metabolic acidosis which is compensated. Now the anion gap comes to 27.9, so this is a high anion gap metabolic acidosis. So final diagnosis is fully compensated high anion gap metabolic acidosis, that is probably diabetic ketoacidosis.